Good morning, ladies and gentlemen. For the next 15 to 20 minutes, I am going to talk about the cardio-renal endpoints in clinical trials. And since this is a very vast topic, and we are in the AKI meeting, I decided we are going to talk about the acute cardio-renal syndrome and the cardio-renal endpoints that are used in acute cardio-renal syndrome. These are my current disclosures. Well, FDA asks us when we want to use a new intervention, whether it is a drug or is a procedure, it should improve how the patient feels, functions, or survives. As such, a patient, whatever we do, the procedure or the intervention should result in a benefit that is detectable by the patient, or reduces the chances of developing a condition or disease such as heart failure rehospitalization here, and at the same time, if we can, to improve the survival. So an endpoint should measure one of these three. If we look at the spectrum of endpoints that have been used in cardio-renal trials, we see that the most scientifically rigorous would be still the hard all-cause mortality. And then we can come to the lowest level that is subject to interpretability, which are, for example, the biomarkers that we talked about. And in between, there are a number of other endpoints, such as cardiovascular mortality. As you know, congestion is the main reason why a patient with heart failure comes to the hospital, as opposed to the common belief that it is low perfusion or end-organ hypoperfusion that brings them to the hospital. Most of them come with a blood pressure of 120 over 80 actually to the hospital. They come for congestion. And during the hospitalization, we use a number of interventions to treat them. For example, in a database of over 150,000 patients, obviously IV diuretics have been shown to be by far the most commonly used medicine for that, followed by others. I didn't put ultrafiltration here. This is a topic of discussion, hopefully this afternoon. In order to find the endpoint, it's good to look at the natural course of the disease. This will tell us what endpoints to go for. So we have a patient who has chronic heart failure. At some point in his life, he will get acute decompensation and needs to come to the hospital. During the hospitalization, he will be treated by us to be decongested. Remember, congestion is the main reason why he has come to the hospital. While we are treating him, 1/4 to 1/3 of the patients will develop increase in serum creatinine, like Professor Ronco very rightly mentioned. We don't like to use worsening renal function, but this is the most commonly expression we use. And then some of these patients, after they have been stabilized, at some point later, they go back to the hospital because of recurrence of acute heart failure. And in between, some people will die. If you look at this figure, we will see what endpoints we should go for. We should go for rehospitalization, increase in serum creatinine, mortality, and decongestion that we can use fluid removal, weight change, or improvement in shortness of breath as the markers for. So that's the cardio-renal endpoints that have been used in clinical trials. And obviously, there have been a number of markers that have been used to measure all these endpoints. I can't obviously go through all of them, but I would like, before going to renal function, which is the focus of this session, I would like to talk just a couple minutes about congestion here. Some people ask, maybe we should use fluid removal and weight loss interchangeably, one or the other. Why the studies use both? This is the reason why studies should use both. Well, a couple years ago, a study that used the data from 3 different studies, DOSE, ESCAPE, and the cohort from University of Pennsylvania, was published in American Journal of Medicine. They wanted to look at the correlation between fluid loss and weight loss. Some people go for one, some people go for the other. Remember, if they are very close, if they correlate very well, the difference between them should be zero. They are equal, right? One minus the other. This is what we see in the y-axis. They are not. There is a major dispersion of the dots. It just tells you they are not correlated very well. On the x-axis is the mean change of weight and net fluid loss, which in these 3 studies actually was shown to be around 5 to 7 kilograms, right? In every patient that comes for heart failure, on average, they lose 5 to 7 kilograms, but it tells you that there is no good correlation between weight loss and fluid removal. And if you look at every day of the hospitalization, it is interesting. This is only from those, not the other 2 cohorts. It tells you that at the beginning, the correlation is bad, but it gets worse as we go. So 24 to 48 hours, the R is 0.47. The next day is go to 0.3, and the next day goes to 0.23. Please keep that in mind. That was all I wanted to talk about in congestion. Now let's go to acute kidney injury. Before I start, just remember that we can use it in different ways. These are just some examples. And again, you remember that blood urea nitrogen, BUN, is not really a measure of kidney function in heart failure. It might be a measure of neurohormonal activity. There have been some data on it, but today we don't talk about it. Well, why do we use increase in serum creatinine as a surrogate endpoint in heart failure trials? Because we think it should be a good substitute for a clinically meaningful endpoint, which is validated. In other words, I have the intervention here, whether it is diuretic or ultrafiltration or whatever. It gives me increase in serum creatinine, and I think that this increase in serum creatinine will give me adverse outcomes. This is where I want to know if it is really validated in acute heart failure. This study was published about 15 years ago, and this showed that as the increase in creatinine continues in acute heart failure when we are treating them, the mortality goes up. And look at here, this is a decrease in GFR by 25% or more, and compared to 0.3 is pretty much the same. And this is the basis for the definition of acute cardio-renal syndrome. It is commonly used to define kidney injury for us, saying that the creatinine goes up by 0.3 or the GFR comes down by 25% or more. This has been commonly used. Let's take a look at ESCAPE trial. Obviously, all of you are very familiar with it. It was just trying to compare clinical assessment with Schwann-Ganz in severe heart failure. When you look at the serum creatinine, at baseline, it had a good association or correlation with the outcomes. Also, the creatinine at the time of discharge had a great association with the outcomes. It could predict the outcomes. But when it came to changing creatinine, what we are interested in, actually it had no association with the outcomes. That was the first crack in our belief. Then it came the dose trial. This is the same trial Professor Ranko went through it. I don't go through the details. Remember that we were just trying to see which type of regimen of diuretics is good in acute heart failure. So there were 308 patients. Let me clean up the table. The high dose induced better fluid removal. It also made the creatinine go up, the high dose diuretic, yet it did not change the outcome. Again, it was the same concept. This is another way of showing it. The high dose is associated with higher levels of creatinine, but the outcomes are pretty much the same over the next 60 days. Steve Koka from Mount Sinai, a couple years ago, did a meta-analysis. This is not in heart failure. This is AKI group. Nearly 50,000 patients in 7 randomized controlled trials looked at the interventions that increased the risk of AKI. right? Well, they didn't really change the chronic kidney disease nor mortality, and this is in AKI. This is a short-term increase in creatinine. Again, renal function reserve is something to consider. They were not considered in these studies. And when they looked at another 7 randomized controlled trials that decreased the risk of AKI, they saw the same thing. They decreased the risk of AKI, but they did not change the CKD or mortality. Well, maybe biomarkers can be helpful. Dr. Whaley Connell went through them so nicely that I don't have to spend much time on it. We know that they have been helpful in heart failure to some limited extent, as he very well mentioned. We are not that sure about them, but they have been used in some trials. And this trial just came out a few weeks ago. This tried to see the correlation between cystatin C or creatinine with 3 biomarkers in heart failure: NAG, NGAL, and KEM1. And as you see, there is not a lot of correlation between these two. Here is the cystatin, here is the creatinine, and this is NGAL, NAG, and KEM1. There is a little bit of correlation here, R of 0.17. But the reality is that clinically it's not very meaningful. And this is an ad hoc of Rose acute heart failure. When they looked to see if they can find a linear relationship between the levels and the AKI as defined by serum creatinine or cystatin change, they couldn't find any. And let's move forward. When they looked at worsening renal function compared to no worsening renal function, the pink is worsening renal function and purple is no worsening renal function, they couldn't find any difference in the biomarkers of tubular injury. Think about it. The patient is getting worsening renal function by creatinine and cystatin, but it doesn't have any effect on the biomarkers of tubular injury, whether proximal or distal. And if anything, actually there is a small decrease here in NAG as the patient is getting worsening renal function. Well, a little bit disturbing is that if your creatinine goes down or stays stable and your biomarkers of tubular injury go down, you would think that you will have a better outcome. Actually, it is the worst outcome. In other words, if you have a kidney dysfunction, either by serum creatinine or by biomarkers, you will do the best. This is the complete opposite of what most of us would think. That's why, as Professor Ranko very correctly mentioned, there's a little bit of discrepancy how we should really define AKI in the context of heart failure. There have been several different ways of defining it. The rise in creatinine has been called AKI, benign AKI, worse renal function in the cardiology literature, pseudo-worsening renal function, different ways. I think I will stick to rise in creatinine because I really don't know what it really implies. To move on, again, Professor Ranko just mentioned this briefly. This is from Professor Metra a few years ago. Let's clean up the table. It showed us that if you look at worsening renal function, which is the same as creatinine increasing by 0.3, and congestion, and consider that the patients without congestion and without worsening renal function are the best, the reference, it tells us that somebody who has worsening renal function, it doesn't change the outcome apparently. So when congestion is taken into consideration, renal function kind of loses its significance. And this is not the only study that showed that. This is another way of showing it. This is the same study. Kaplan-Meier tells us that worsening renal function with congestion is definitely bad. But if you have worsening renal function without congestion, you are no different from somebody who did not have worsening renal function. Jeff Testani had shown this 1 year before that, that if you have worsening renal function with congestion, you are in worse shape. Otherwise, doesn't matter. This is only on 386 patients, right? And this is retrospective study, so we take the data with a grain of salt. But this study came out a few weeks ago, again from the same group, but this time, this is an ad hoc of PROTECT with over 1,500 patients. It shows, again, the same concept. Here, actually, it's a little bit difficult to interpret. When you look at it, this is on the y-axis is the worsening renal function, and on the x-axis is the day they checked congestion and the same day that they checked the serum creatinine. What it tells us, this is stratified by congestion, red line, versus no congestion, black line. What it tells us is that if you don't have congestion, worsening renal function does not have an impact on your mortality. But if you have congestion, you have 50% increase in the risk of mortality. The same concept here with all-cause mortality. The difference between them was not statistically significant between congestion and without congestion, but the trend is still there. When they looked at the length of stay, again, they saw it, and this time it was significant. The trend is there. It increases the worsening renal function, increases your length of stay only if it is associated with congestion. If not, it doesn't. If you look at the cardio-renal studies that have been done, there haven't been a lot that have been focused on cardio-renal. We are not talking about acute heart failure, right? There are 3 of them, PROTECT, CARES, and ROSE acute heart failure. You remember that PROTECT was A1 receptor antagonist, CARES heart failure was ultrafiltration. Hopefully this afternoon I'm going to talk about it much more in detail. And ROSE acute heart failure is necessitide, dopamine, and placebo with diuretics, right? The 3 of them showed neutral effects actually. So to this date, we don't have a good treatment for acute cardio-renal syndrome. A stabilization of heart failure is definitely good, but that would be anyways be done for any patient with acute heart failure, whether they have renal dysfunction or not. So if I want to have a take-home message, I think that the changes in renal function is mechanistically relevant endpoint, as I showed in that scheme. I think that changes in serum creatinine do not necessarily reflect tubular injury in heart failure. It might not be an ideal endpoint because of this when it is used alone. Obviously, as bivariate endpoints or using with combination with others, it would be very meaningful. Decongestion should be considered an endpoint along with measures of renal function. Decongestion probably is important. A very exaggerated view is that an editorial came out a few years ago on an editorial on one of these studies. It was saying in acute heart failure, treat heart failure, forget about the kidney. I don't think we should forget about the kidney, but it just wants to tell us that congestion is something to really think about when we are dealing with these patients. While the renal biomarkers are promising, as Dr. Whaley-Connell went through them, the therapeutic implications are yet to be clarified in the setting of heart failure. And I think when we looked at congestion, I should have mentioned, maybe we need to use more sophisticated measures than the usual weight and fluid loss to measure our decongestive strategies. If we combine them, hopefully we will have a better result, subjectives and objectives, as well as the serum creatinine and the biomarkers. Combining them, hopefully we'll have better results. And with this, I have to finish my presentation. I thank you for your attention.